In this module, we will explore segmental wall motion of the left ventricle. To review from the probe positioning module, recall that the standard images are obtained in the upper esophagus, mid-esophagus, and transgastric levels. The mid-esophagus and transgastric planes are most useful for imaging ventricular function and wall motion. A key concept in the imaging of the left ventricle is that imaging in the short axis only shows a thin slice of the ventricle. Thus, in order to get a sense of wall motion and ventricular function for the entire left ventricle, it must be assessed at 3 different levels: mid-papillary, basal, and apical. Evaluating all 3 of these levels provides a comprehensive sense of left ventricular function. In assessment of the left ventricle, the American Society of Echocardiography and Society for Cardiovascular Anesthesia endorse a 17-segment model. The mid and basal levels each have 6 segments: anterior, inferior, septal, lateral, anteroseptal, and inferolateral. The apical level has 4 segments: anterior, inferior, septal, and lateral. The 17th segment is the apical cap, which is often difficult to visualize by TEE. Another key concept in the assessment of left ventricular function is understanding the distribution of coronary blood flow to each of the left ventricular walls. One reason the transgastric mid-papillary short axis view is so useful is that it allows the echocardiographer to see blood flow from all the cardinal coronary arteries in the same view. Anteroseptal and anterior walls are fed by the LAD. The lateral and inferolateral, previously posterior, walls are fed by the circumflex, and the inferior, and in most cases the septal, walls are fed by the RCA. Wall motion is graded as normal, hypokinetic, akinetic, or dyskinetic. Normal wall motion involves wall thickening of over 30% in systole. Hypokinetic wall thickening occurs when thickening is between 10 and 30%. Note the global hypokinesis, which is worse in the anteroseptal and anterior portions of this echo. Akinesis is defined as wall thickening of less than 10%, as seen in all but the lateral and inferolateral walls of this image. Dyskinesis occurs when a segment moves outward in systole instead of contracting inward and thickening. In this image, the inferior wall is dyskinetic and exhibits paradoxical movement with systole. There are a number of reasons that a heart which is not ischemic may appear thickened or have regional wall motion abnormalities. Hypertrophy, increased afterload, dilated cardiomyopathy, and left bundle branch block with septal wall motion abnormalities can all lead to atypical motion or appearance of the heart. This series of images demonstrates the progression of concentric left ventricular hypertrophy. Over time, in response to conditions such as chronic hypertension or aortic stenosis, the heart responds by thickening in order to increase its ability to contract and eject blood against a high afterload. Over time, this heart may have difficulty delivering blood to all its tissue and become more easily ischemic. On TEE, the walls appear thick and the LV chamber is easily obliterated during systole. This series of images reflects the results of volume overload on the left heart, which manifests as progressive dilation and thinning of the left ventricular walls. Ultimately, the walls are unable to contract well and result in a declining ejection fraction. The TEE image demonstrates a dilated and thinned left ventricle, which has become globally hypocontractile. This slide shows the probe positions and images acquired in transgastric views. These views are obtained by advancing the probe into the stomach. Most proximally, the basal transgastric or fish mouth view can be seen. This shows the mitral valve apparatus and the basal segments of the left ventricle. Advancing the probe and slightly antiflexing the probe will show the mid-papillary transgastric view, which shows the mid-segments of the left ventricle. The next view seen here is a transgastric long axis view. From a mid-papillary view, the probe is rotated to between 90 and 120 degrees until the left ventricle is seen with the base on the right of the screen and apex on the left. In this view, the left atrium, left ventricle, mitral valve, and its support structures can be seen. It is important to evaluate wall motion in both long and short axes. In the following images, please evaluate the wall motion for each successive patient. In this patient, we see normal wall motion with symmetric left ventricular hypertrophy, seen particularly in the transgastric view. Assess the wall motion in the following patient. In this patient, LV function is normal, but RV function appears at least moderately to severely hypokinetic. Please assess the wall motion in the following patient. This patient exhibits akinesis of the septum, seen in both views, characterized by lack of movement of the septal myocardium. This differs from dyskinesis, which would result in paradoxical wall motion. Application of an aortic cross clamp can dramatically increase afterload and cause ischemia and changes in wall motion. Can you identify the wall motion change with clamping? Here we see the development of anterior dyskinesis with cross-clamp application. The inferior wall may also be hypokinetic, but may have been so pre-cross-clamp as well. Identify the wall motion abnormality. The anteroseptal wall in these images moves poorly at the base and not at all in the mid and apical regions. Can you identify the abnormality depicted in the schematic and echo image? The abnormality here is an inferior wall aneurysm, which can result after a myocardial infarction in the RCA territory. Note the characteristic bulging of the basal and mid-aneurysmal wall seen here. Integrate the information from the following images to identify the wall motion abnormality. Note that the inferior basal segment moves paradoxically in all three views: the mid-esophageal two-chamber view, the transgastric basal view, and the transgastric long axis view. Identify the view and wall motion abnormality depicted here. In this mid-esophageal two-chamber view, we see severe inferior wall hypokinesis, delineated by the bracket. This is on the border of akinesis. Identify the view and wall motion abnormality. In the transgastric mid-papillary view, we see dyskinesis of the anteroseptal wall. This is a more subtle wall motion abnormality. Can you identify the view and wall motion abnormality? In the mid-papillary view, we see mild inferior wall hypokinesis. Please identify the view and wall motion abnormality. Here we see severe anterior wall hypokinesis in the transgastric mid-papillary view. Please identify the view and wall motion abnormality. Here we see inferior wall dyskinesis in the transgastric mid-papillary view. Please identify the view and wall motion abnormality in this post-bypass patient. Here we see atypical septal wall motion in the transgastric mid-papillary view. The septum appears to be dyskinetic, but looking at the ECG, we can see the patient is ventricularly paced, which can explain this paradoxical septal motion. Please identify the view and wall motion abnormality in this post-bypass patient. Here we see a mid-esophageal commissural view of the mitral valve. In this view, we can see that the apex and apical cap are akinetic. This allows for low blood flow at the apex and is a setup for a possible apical thrombus, so a careful examination should be done focusing on this area to rule a thrombus out. Please identify the view and wall motion abnormality. Here we see moderate to severe septal wall hypokinesis in the transgastric mid-papillary view. In conclusion, with practice, you will be able to discern abnormalities in wall motion through careful assessment in multiple planes. A thorough examination of all 17 segments requires both mid-esophageal and transgastric imaging to corroborate findings.